Hello, I am Dr. Sandeep Salvi, the Director of the Chest Research Foundation situated in the city of Pune in India. I am going to tell you how to differentiate between asthma and COPD in your clinic. You have heard from the previous talks that asthma is a personality disorder of the airways that is associated with a panic reaction of the airways. And this is beautifully shown by this example over here of the touch me not plant. The moment you touch it, all the leaves start closing. This is classically called as bronchial hyperresponsiveness and is the characteristic or the hallmark feature of asthma. Asthmatic patients, in response to cold air or histamine or exercise or other chemicals such as adenosine monophosphate, show a significant bronchoconstriction after exposure to these. This is classically called as bronchial hyperresponsiveness. In contrast to that, COPD is a disease that is associated with a toxic insult to the airways over a period of time. And you can see that the COPD lung looks very different because of long-term exposure to these pollutants. It looks black in color, big in size, and is associated with a big size heart. The problem occurs across all the parts of the lung, but predominantly in the small airways and in the lung parenchyma, where the damage is the most. So in clinical practice, you know that asthma and COPD are very different diseases. But when the patient comes to you, they come to you with the same symptoms of cough, shortness of breath, wheeze and chest tightness. And here it may be a challenge to diagnose whether this is asthma or whether this is COPD. It may be difficult at times to differentiate between these two very common conditions that we see in clinical practice. So what I'm going to share with you is a thought process that I have that you may use to differentiate between asthma and COPD and make a diagnosis a little more confidently than what you could before. So first and foremost, you must take a good and detailed history, because that is going to give you a lot of clues whether this is asthma or whether this is COPD. This should be followed by a good clinical examination. If you look for certain signs and you find them, you know that this is more likely to be asthma or more likely to be COPD. And I'll share with you these secrets. And finally, if you have access to a lung function test such as a spirometer or a peak flow meter, then how to use these tools in not only making a diagnosis but also differentiating between asthma and COPD. So let us start with a good history taking. When did your symptoms start? When did your symptoms of cough and breathlessness start? If the patient says that the symptoms started before the age of 40, it started earlier in my life, then you know that this is unlikely to be COPD. In contrast, if the patient says that my symptoms of cough and breathlessness have started after the age of 40, then you know that this may be COPD, but you certainly cannot rule out asthma also in this case. However, if the patient says that I have been having these symptoms since childhood, then you know that this is more likely to be asthma than COPD. In the past, did you suffer with any of these ailments? Asthma, allergic rhinitis, rhinoconjunctivitis, eczema or any form of skin rash, or even migraine? This is an important question that you must ask all your patients in whom you are suspecting a diagnosis of asthma or COPD. Why is it important? If there is a past history of any of these, then you know that this patient is now more likely to have asthma than COPD. A combination of all these ailments called asthma, allergic rhinitis, rhinoconjunctivitis, eczema, migraine are called atopy. So if your patient has a past history of atopy, then the symptoms that he has come to you today is likely to be due to underlying asthma rather than COPD. Similarly, if anybody in the family of that patient had any of these atopic diseases, then the diagnosis goes a little more in favor of asthma. This is because we all know that asthma is a very strong genetic disease. In fact, it is one of the most strongest heritable disease that you can get. So if there is a family history of asthma, then there's a very strong pan that goes in the strong weight that goes in the pan of asthma. So family history of atopy goes more in favor of a diagnosis of asthma. These are the symptoms that you should ask with respect to the cough. Do you have a dry cough after exercise? Do you have a dry cough after laughing? After exposure to dust? After exposure to perfumes or sprays or paints or varnishes? Or does your cough start at around 3 o'clock in the morning, between 3 to 4 in the morning? Is your cough associated with breathlessness when there is a cloudy weather? If the answer to any of these is yes, then you know that this is more likely to be asthma, because asthmatic cough is very characteristically associated with all the features that I have just mentioned to you. Have you noticed a wheeze, a musical sound or a whistling sound coming from your chest whenever you have a cough or whenever you feel short of breath? And the patient says, yes, I can hear the wheeze myself, I can hear the whistling myself in the chest. Then you know that this is more likely to be asthma than COPD. So asking the patient about this symptom is a very strong marker towards an underlying diagnosis of asthma. Are your symptoms episodic? Do you ever feel normal between episodes? And are your symptoms particularly seasonal? Very important question to ask. Because if the answer to this is yes, then the diagnosis goes more in favor of asthma. So cough that is episodic, cough that is there all the time, but there are periods of normalcy between that, and a cough that is associated with seasonal changes is strongly indicative of underlying asthma. Do your symptoms get worse when you're exposed to pollen grains, or do you have damp walls at home? Do you have pets such as cats at home? Is your house very dusty? What kind of occupation are you associated with? And certain occupations are very strongly associated with asthma. For example, bakery workers, soldering, welding, very strongly associated with asthma. So if the answer to any of these environmental risk factors is yes, then we know that the patient is more likely to have asthma than an underlying COPD. Do you also suffer from gastroesophageal reflux disease, heartburn? Are you anxious by nature? And have you been a bright student in the past, or have you achieved a lot of things in your past? Why is this important? Asthma is associated with gastroesophageal reflux disease. Asthmatics are a little more anxious by nature, and asthma seems to be a God gift to many people, because many of these asthmatics achieve a lot in their life, not only in academics but even in sports, in social, cultural, all sorts of activities. Asthmatics seem to do well. So I like to ask this question to my patient. If the answer is yes, then I know that this person is likely to have asthma rather than COPD. Do you also suffer with hypertension? Has anybody diagnosed you with hypertension or ischemic heart disease or diabetes or thinning of your bones, muscle weakness, or have you been depressed in the past? These are important comorbidities that are associated with COPD. So if your patient says, yes, doctor, I've been suffering with high heart disease and high blood pressure for the last 5 years, associated of course with the respiratory symptoms, then you know that this is more likely to be COPD than asthma. Do you smoke tobacco? Obviously, this is an important risk factor that is associated with COPD. So the patient says, yes, doctor, I smoke BDs, I smoke cigarettes, or I smoke hookahs, and I've been doing that for the last so many years, and I have these respiratory symptoms. Obviously, you would think of a possibility of COPD rather than asthma, because these are important risk factors associated with COPD. What are the other risk factors associated with COPD? Use of biomass fuel for cooking. So women who have cooked food on the chullas for many years in the past, they may be using an LPG gas today, but in the past they have been exposed to biomass smoke for 20 years. then we know that they have had sufficient exposures that make them more vulnerable to develop COPD. So a yes to this question suggests that they have had sufficient exposures that make them vulnerable to have COPD. Mosquito coils. So some homes use mosquito coils every day for many years, and perhaps you may not be aware of this, but burning one mosquito coil in the night emits as much amount of smoke that is equal to smoking 100 cigarettes. 100 cigarettes of exposure every day for a long period of time, is a very strong risk factor associated with COPD. Or if you are exposed to high levels of outdoor air pollution, you have a shop just next to the main road, you're a hawker, you sell stuff on the road, or you're a rickshaw driver or a bus driver, where you're exposed to high levels of air pollution, then we know that these are patients who are more likely to be COPD than asthma, because they have been exposed to high levels of environmental toxicants. Doctor, my symptoms improved magically when some doctor gave me steroids, whether they were oral steroids or whether they were inhaled corticosteroids. If you get that answer, then you should certainly think of an underlying diagnosis of asthma, because asthma is one disease that responds magically to steroids, whether it is oral corticosteroids or whether it is inhaled corticosteroids. So this particular answer that you get from a patient is a very strong indicator of an underlying diagnosis of asthma. COPD patients don't have such dramatic magical response to corticosteroids. Here are two statements, and I think listen to these two statements carefully, because each one of them is giving you a clue as to what is the underlying diagnosis. Doctor, I feel short of breath quite often, but there are times when I feel perfectly normal. And here is another patient who's come to you with saying, Doctor, I feel short of breath all the time. Sometimes it's more, sometimes it's less, but there is no period when I'm not short of breath. Can you tell me what is the diagnosis in the first one? Obviously, it is asthma. When I tell you that you have periods of normalcy in between the symptoms, then it is very likely to be asthma. And in contrast to that, patients of COPD, they will have the symptoms all the time. They will never be normal in between two episodes of attacks that they have. So I think getting an answer from your patient, one of these two sentences is very useful to make an underlying diagnosis of asthma COPD. So this is all about history. Taking a good history, it will tell you what is my patient likely having, more of asthma or more of COPD. Then let's talk about clinical examination. So here is a patient whom you have started doing a clinical exam and you find that this patient has got a hyperinflated chest, or this patient is breathing with a pursed lip like this, or if the patient has got peripheral edema, has got a raised JVP, is this asthma or is this COPD? This is clearly COPD, isn't it? So hyperinflated chest, pursed lip breathing, and features of heart failure go in favor of a diagnosis of COPD. So you're catching the clues on clinical examination. If you have an access to a chest X-ray and you find that the chest X-ray showing hyperlucent lungs, nice big hyperlucent lungs, small thin heart, low flat diaphragms, then you know that this is COPD, because asthma doesn't present with these features at all. One very interesting new feature of COPD, we have noticed nowadays are some of these things that I've just shown you in front of you. Muscle wasting. Many patients of COPD, they lose a lot of their muscles because the proteins are lost. So they have hardly any muscles in the upper part of the body, or even there's wasting of the muscles in the thighs. So the moment you see this feature, you know that this patient is more likely to have COPD. There has been a lot of talk about presence of facial wrinkles or the wrinkling seen on the face as a marker of underlying COPD. And this has been shown in many studies across the world, that patients of COPD tend to have more facial wrinkles than those who do not have COPD. So look for these and it might give you a small clue that there is an underlying COPD. If you look at the lungs of patients of COPD who have predominantly emphysema, you can see that there are literally holes in the lung because of damage and destruction of the alveoli. Now, if you take a cut section of the bones of these patients, you will find more or less the same thing, that there are holes in the bones as well, and this is because of osteoporosis. So if your patient has got osteoporosis, has got facial wrinkles, has lost a lot of weight, and there's hardly any muscle left on the thigh, then you know that this is more likely to be COPD than asthma. On the other hand, if your patient has got all these signs of eczema, either on the wrist or the ankle or the elbow, or you can see they're called as allergic shiners just below the eye, or there is presence of allergic rhinoconjunctivitis. This is classically suggestive of an atopic underlying disease. Therefore, if this patient comes to you with a respiratory symptom, then you know that this patient is more likely to have asthma rather than COPD. Spirometry is an important diagnostic test that not only helps in the diagnosis of asthma but also helps in differentiating between asthma and COPD. So, if you are well versed with spirometry, the defining criteria for obstructive airway disease is the ratio between FeV1 upon FVC, which has to be less than 70%. So, if that is the case, then you know that patient has obstructive airway disease. Now you give a short-acting bronchodilator, and after giving a short-acting bronchodilator, if the ratio now becomes more than 70%, then this is asthma, and if the ratio remains less than 70%, then this is COPD. In fact, this is the defining criteria between asthma and COPD using spirometry. One of the other features that patients of asthma have is a good bronchodilator reversibility. What do I mean by a good bronchodilator reversibility? Improvement in FEV1 by more than or equal to 12% and more than or equal to 200 ml absolute change is indicative of a good bronchodilator reversibility. And if you do find this, then you know that this patient is more likely to have asthma than COPD. However, we also know that many of these COPD patients can also show good bronchodilator reversibility. So, using this criteria to distinguish between asthma and COPD may perhaps be a weak one. However, if the improvement in FEV1 is more than 400 milliliters, absolute improvement after a short-acting bronchodilator, it can only be asthma. It's very unlikely to be COPD. Because such a big improvement in FEV1 is only seen in patients of asthma. Can you use a peak flow meter to diagnose asthma in your clinic? Yes, you can. In fact, a peak flow meter can be used in 3 different ways to make a diagnosis of underlying asthma. And this is if you do not have an access to spirometry. For example, you may give a therapeutic trial of inhaled corticosteroids to your patient and then look at the change in the peak expiratory flow rate before the start of the treatment and after 4 weeks of treatment. And if your PEFR improves by more than 20%, then you can be almost confident that this is asthma and not COPD. Similarly, you could also look for diurnal variability, that is morning PEFR values versus evening PEFR values. Give the patient a peak flow meter to take home, ask the patient to do 3 blows in the morning, 3 blows in the evening, record the highest and look at the differences between the morning and evening PFR values. If the difference is more than 10% in adults, more than 13% in children, then this is very strongly indicative of underlying bronchial asthma. And finally, you can also use a peak flow meter to diagnose asthma by asking the patient to do a little bit of exercise, run around the clinic, go for a walk, quick brisk walk, and then come back again and then do the peak flow metry values. If the PFR values drop by more than 15% after a certain amount of exercise, then this is indicative of an underlying asthma rather than COPD. So you can use a peak flow meter to diagnose and distinguish between asthma and COPD. Now here are some important questions that I would like you to ask your patients, such as if there's children, for example. How can you get clues from the history about whether this is asthma or not? Ask the parents, did the child have eczema during early childhood? Important, isn't it? Because past history of atopy. Did or does anybody in your family have asthma, allergic rhinitis or other atopic diseases? And was the child born by a cesarean delivery? All important risk factors associated with asthma. So if the answer is yes, then you know that your child is more likely to have asthma than anything else. If the parent says that I have noticed that my child coughs a lot when he goes out to play with the friends, or the parent says, my child coughs when he laughs a lot, or my child catches a viral upper respiratory tract infections more frequently than other children, and these usually last for a longer period of time than other children. These are very classical clues to say that the child has underlying asthma than anything else. So ask these. But be careful, because there are a lot of mimics for asthma, or there are mimics for COPD. They present with the same symptoms. And here is a table that tells you what are the mimics for asthma for adults and what are the mimics for asthma for children. And you can see that for adults, the differential diagnosis for the same symptoms could be COPD, heart failure, bronchiectasis, gastroesophageal reflux disease, endobronchial tuberculosis, perhaps an underlying lung tumor or a tumor in the airway, or tropical eosinophilia. They can present exactly as what asthmatics and COPD patients present with. So you be careful and take a more detailed history to rule out these underlying conditions. Similarly, for children under the age of 5 years, you can have congenital deformities of the airways, or even congenital heart disease can also be a mimic for asthma. Foreign body aspiration is very common. In fact, many children are wrongly treated for asthma, when in fact it was because of an underlying foreign body that was there in the airways for a long period of time. And many of these children can also have a gastroesophageal reflux, which mimics asthma in these children. And then finally, if your child is between 5 to 12 years, then the list of mimics are given over here, such as tuberculosis, bronchiectasis, adenoidal hypertrophy is very common mimic of asthma. Similarly, foreign body aspiration, or even cystic fibrosis, although it's not very common, but you should have a suspicion if the symptoms are high. So these are the mimics that you should be careful about before you make a final diagnosis. If it is important for you to ask a set of other important symptoms and questions, say for example the patient also has an associated chest pain, then you know that this is unlikely to be asthma COPD. It probably is because of an underlying ischemic heart disease or something else. Similarly, if the patient complains of fever, then you know that it is because of an underlying infection. Could be a bacterial infection, could be a tubercular infection, or it could be because of underlying bronchiectasis. So these patients will come to you with presence of fever. A significant weight loss over a fairly short period of time with the respiratory symptoms. Certainly think about tuberculosis and lung cancer as two differential diagnoses. Patient with respiratory symptoms but comes to you with orthopnea, feels breathless on walking, feels breathless on lying down, and then classical post-paroxysmal nocturnal dyspnea. Need to get up in the middle of the night, open up the windows, get fresh air, and then feel better. This is underlying heart failure, so you should be very careful of that. If a patient has respiratory symptoms with hemoptysis, tuberculosis, lung cancer, bronchiectasis are the three important differential diagnoses that you should look for. So ask for these symptoms, and so that you will not make a mistake of missing out the other potential diagnosis. So the same table over here that talks about pulmonary tuberculosis. When should you suspect pulmonary tuberculosis in your patient? When should you suspect bronchiectasis? When should you suspect heart failure? All those features are very nicely given in this table, and if you have a close look, you will be able to use this knowledge to pick up these differential diagnoses. And then there is a very nice table prepared by Dr. Randeep Guleria, who is currently the director of All India Institute of Medical Sciences. So he, along with a team of experts, made this document mainly for primary care physicians, to help them in evaluating these patients with respiratory symptoms. And what he classically tells us is that if your patient has come to you with chronic respiratory symptoms, the patient is more than 35 years of age, has been exposed to risk factors such as tobacco smoke or biomass smoke or occupational smoke exposures, has classical respiratory symptoms, then you should suspect an underlying COPD in this patient. But because the patient has got symptoms for more than 2 weeks, and in India tuberculosis is so common, it is wise to get a sputum AFB done in all patients who have a cough for more than 2 weeks. If the sputum AFB is negative, then obviously you should think of an underlying diagnosis of COPD, get more clues from the history, do spirometry if it is possible, and then start your patient for the treatment of COPD. If the sputum for AFB is obviously positive, then you treat this patient for underlying pulmonary tuberculosis. So I think these are very simple algorithms that have been developed to help you in not making a wrong diagnosis in some of your patients. Thank you very much.